practice pediatrics at Riverside. For those of you who don't work in a pediatric unit or don't have small children, we coined the title of our committee 13 by 2 because by age 2, children have received 13 injections. And I know that my nurse Jennifer knows how many injections children receive. And she happens to be on my committee. First of all, I'd like to thank our committee. Whoever's here, please stand up. We had Dave Griffin, my nurse Jennifer Pfeiffer, Judy Jardy, Dana Lagness. We have Sir in the back. We had Nora, and Saeed is our interpreter at Health Partners Riverside Clinic. Our committee was extraordinary. We were extremely consistent in our meeting attendance. People were really dedicated to the cause. Our secret weapon, of course, for success was Judy Jardy. I don't know how many of you have worked with Judy Jardy, but Judy keeps you on task. I don't know how many other committees had a timekeeper for each meeting, but we do that at our meetings. And we met religiously every 2 weeks from day one. We did take Thanksgiving off. So it was a great committee. And we had Dana's help in terms, and both Dana and Judy were very good at really striking what the aim was, because I think that was critical for the success of this committee. So our goal was to increase the immunization rates for two-year-old East African children, and our 2 clinics that we focused on were Brooklyn Center and Riverside. And so our focus was fairly narrow, and what we looked at was children in the age group of 18 to 23 months, East Africans, and those who were not up to date. And rather than just strictly looking at immunization rates, we looked at missed opportunities. And so we would define a missed opportunity as if a child came into one of our clinics for whatever reason to see a provider and at one of these 2 sites and was not given a vaccine in that age group. And so if you look at this graph, particularly Brooklyn Center, was pretty high to start with in January. And our goal was to have 2 or less missed opportunities. And as you can see by the maroon line across the bottom. And not that I'm a competitive person, but Riverside did beat Brooklyn Center. And on a consistent basis. Brooklyn Center did meet the goal twice during that time period. So the measure was, of course, we did decrease the number of missed opportunities. What we were a little bit disappointed was our attempt at developing community gatherings. We did have fantastic community advisors in Nora and Sura. They really gave us a lot of knowledge regarding this community that really helped us in terms of addressing immunizations in the clinic settings. But our community gathering just did not work out well. We had about a dozen people there, and other than Nazra Ahmed, who was we borrowed her from the colorectal committee. She came in on just a beautiful Saturday afternoon. We met at the Brian Coyle Center, anticipating to have many community parents from the community join us to discuss vaccines. Not one person came, and the food that we had donated, people from the community had donated to our endeavor was consumed primarily by young children who were there working out at the Brian Coyle Center. So, obviously, people who work at inter-center clinics, they already know what the challenges are regarding vaccines among East African children. There's a lot of fear about the safety of these vaccines. Certainly there are many children with autism who are East African, and so we knew that going into it. But I think by maintaining logs that our nursing staff really helped to keep, to identify which vaccines specifically parents were refusing, why they were refusing them, and how we could make changes in our workflow to increase the immunizations. really made our endeavor very successful. The immunization expert panel had brought forward some really great ideas in terms of ways to address the issue of missed opportunities. Unfortunately, those recommendations really never trickled down to the frontline staff. And so Judy brought a couple of these recommendations to our group and really helped us in terms of implementing those. And I'll speak to those a little later here. And then clearly, at every opportunity, we encourage physicians and nursing staff to talk about reasons for vaccinating their children, even at ill visits. Sustainability, I think that, sustainability and spread, in my mind, are the two most important things that come out of these committees. We, at Health Partners, we use care model process to have our nursing staff verify the immunization status of all children as they come in, whether they're coming in for an acute visit or a well child visit. And so there is a state registry that our nurses can use to obtain that information. And generally, if somebody who's been living in Minnesota for a while, that's the best way to receive that information. Of course, what's more challenging is to break through some of those barriers that are usually among the parents, but among physician staff as well, in terms of when, in what situations you should give immunizations, and then utilize any opportunity, whether it's a child who's somewhat ill, or even sometimes children who are with another child coming in, we'll grab them for the vaccines. The couple things that we implemented in terms of a recommendation from the expert panel. One was to use a nurse referral order that either our nurses or our physicians can put into the order entry. That then, say if a child is extremely ill at the visit and we truly do decline the opportunity to vaccinate the child, then we're able to have that child come back and be scheduled for an appointment in the next week or so. And that can be done not only for vaccine updates, but for well child care as well. And so we also used EPIC tools such as after visit summary, and then Jennifer developed a really nice "It's Okay" poster that is posted in our various exam rooms that again educates parents in terms of that it's reasonable to give vaccinations when children are on antibiotics or if they're ill. As I said, NIC is the name of the immunization registry. Another way that really helped all of us communicate with our colleagues within the clinic is to use the problem list in EPIC, so that when a parent does refuse, say, the MMR, that then we can document, what was the rationale for that parent to refuse it. And so if it's because they have a sibling with autism, that's a little different discussion than if they're simply trying to stagger the schedule of immunizations in a different way, but they're fully engaged in actually immunizing their child. But it helps everybody in the clinic understand the reasons behind some of those parental decisions. And then, of course, to immunize children at ill visits. We've also had some improvements with after visit summary, where we can denote specifically what vaccines are recommended. So we're trying to catch up these children if, for example, a relatively new immigrant or refugee might be way behind, and then we can denote specifically which vaccines need to be given at future visits and the timing of such. I already mentioned the nurse visit, and then the OK poster. And then another important thing that we use now is that each CDS at all of our clinics, our care delivery supervisor or nursing supervisor, receives a list of those children who are not up to date. And so they can turn that over to reception staff and nursing staff, so that it's kind of a hit list for which children need to come back in for vaccines. There is resistance to administering vaccines on a number of different levels. Sometimes it's a physician who's used to just giving vaccines at well-child visits. They don't really pay much attention to them at acute visits. Well, we of course try to increase the knowledge and the importance of giving immunizations whenever you possibly can, therefore reducing missed opportunities. Sometimes, parents get really busy and they'd rather not bring their child in only for a vaccine appointment. That they'd rather wait until the next well-child appointment. And again, if it's within a month, that's not a big deal. But if it's a child who's 18 months old and will be coming in for another 6 months, obviously that child is at risk during that time period. So obviously we try to encourage those children to come in sooner. The next is educating the East African community and building trust. And I don't know if you guys are still meeting, but we actually met last week. And we were fortunate enough to meet Hodan Hussein. And Hodan is a major immunization advocate. She has a daughter with autism. When she started out, she was very much against vaccinations. And with time, she has realized how inaccurate her information that she had been receiving was. And so now she's become a community advocate for immunizations. And she's an amazing person that, if you could get her out in your clinics to speak to your nursing staff and physician staff, she would make a huge impression. She has been working with the Department of Health and plans to actually have kind of form a grassroots effort to spread knowledge about vaccines. And so she's actually going to train some of her friends and neighbors in her community, and then allow them to become trainers and therefore spread information about accurate information, actual safety and importance of vaccines. In addition, she's planning to do home visits where vaccine safety can be discussed. So unfortunately, we met her, again, right at the end of our efforts here, but so I can see a future, even though I think technically we're done, right, Judy? Thank you.